Good evening, viewers. My name is Rahul Desai, and on behalf of MedTalks and Enerzal Zero, I hereby welcome you all in our today's milestone in our journey of 52 weeks of Diabetes Essentials, Dr. Sanjay Kalra sir. Dear viewers, these online modules are an educational initiative from Enerzal Zero and in memory of late Dr. K.K. Agarwal sir. Among the non-communicable diseases, type 2 diabetes mellitus is the most prevalent with an increasing incidence at alarming rates worldwide. Identification and management of type 2 diabetes mellitus, modifiable risk factors are crucial steps in preventing and decreasing the incidence rate of this disease. Several previous studies suggested that dietary nutrient intakes could be involved in blood glucose homeostasis. And a recent systemic review has also suggested that calcium supplementation might have protective effects on LDL cholesterol and HDL cholesterol in overweight and obese patients. So before I hand over the platform to Dr. Kalra sir to take us through calcium and diabetes, which is the topic of today's module, let me have the opportunity of announcing the name of those doctors who have answered the quiz questions correctly of the last episode. And the names are Dr. Satish Kumar Jain from Karnataka, from Maharashtra, Dr. Anand Purandare, Dr. Dharmika Tandon, Dr. Kulbhushan Tandon, from West Bengal, Dr. Santanu Kumar Bhattacharya. So congratulations, doctors. Dear viewers, on the occasion of World Pre-Diabetes Day, that is on 14th August, we have a very big event coming up where Dr. Julio Rosenstock, director of Dallas Diabetes Research Center, will address the Indian doctors on newer drugs for diabetes. This session will be moderated by our very own Dr. Sanjay Kalra sir. So, dear viewers, to log in to this session, please register yourself on enerza0.com on the link provided on the slide, and kindly help us to reach out to all of your peers who are like to keep update in diabetes. Viewers, previously also we had two biggest events. That is, on 14th November, we had Dr. Om Ganda addressing the doctors on pragmatic approach to choice of glucose lowering therapy. And on 15th April, Dr. Vivian Fonseca addressing on a scientific approach to improving vascular and metabolic health in diabetes. If any of the viewers wants to go to these modules, they are available on the same platform on MedTalks. With this, let me hand over the platform to Dr. Kalra sir. Sir, over to you.
Thank you, Rahul, and good evening, everybody. Once again, it's a great pleasure being with all of you. Today, we'll talk about calcium. We'll talk about something that keeps us strong. Now, ever since we were children, we've always been told by our mothers, drink your milk. Drink your milk, this will make your bones strong. Why is it that they asked us to drink milk? It's because milk is rich in calcium. Is calcium important for people with diabetes? Let's find out. The term that we use when we manage diabetes is osteovigilance. Osteovigilance means that we should remain vigilant about bone health when we are managing diabetes. Why so? Because there are some forms of diabetes where there is a coexistence of bone mineral disease and diabetes. An example, polyglandular autoimmune disease. Polyglandular means multiple glands, all affected due to autoimmune disease. So type 1 diabetes is an autoimmune disease. So is hypoparathyroidism. So you can have type 1 diabetes and hypopara together. Another one, in malignancy, multiple endocrine neoplasia. We can have pancreatic tumor and parathyroid tumor. So if you have a person who is coming in with type 1 diabetes and maybe tetany or maybe generalized weakness, muscle aches and pains, even seizures, it is possible that all these can be due to low calcium. And that low calcium can be due to hypoparathyroidism. If you have a patient who has a parathyroid tumor, do suspect pancreatic tumor as well. If you have a person who has a pancreatic tumor, do screen for parathyroid illness, parathyroid malignancy. And if you have a patient with multiple stones, repeated recurrent stones, urinary stones, then again, parathyroid tumor has to be ruled out. Now, you may say that polyglandular disease, multiple endocrine neoplasia, these are very rare in practice. But type 1 and type 2 diabetes are not rare. These are so common. So actually, children and adults who come with type 1 diabetes, with or without celiac disease, will have a low BMD, low bone mineral density. People with type 2 diabetes, they have been reported to have variable results. Some studies say high BMD, bone mineral density. Others say normal, others say low. But irrespective of that, the density may be high, but the bone quality is low in type 2 diabetes. So in type 1 and type 2 diabetes, we have to be osteovigilant. We have to be osteovigilant also because vitamin D deficiency is endemic in our society. So is diabetes. And even otherwise, there may be a relationship of vitamin D deficiency and diabetes. Vitamin D deficiency is more common in obese people because the vitamin gets sequestered in adipose tissue. So if you have a person with diabetes plus obesity, the risk of low vitamin D is even more. Yet other risk factors in diabetes, there can be premature menopause or late onset hypogonadism in men. This will be associated with poor bone quality or osteoporosis. People with diabetes may have sarcopenia or neuropathy, that is muscle insufficiency or nerve insufficiency, and this too can predispose to fractures, even if the bone density is slightly low. Hypovitaminosis D is associated with metabolic syndrome and impaired cardiovascular health. So it does contribute to a vicious cycle of ill health. And like we said, sometimes the technique can be due to hypocalcemia, at other times it can be due to hypomagnesemia. So this too is quite common. So now you see that we have to be osteovigilant in the OPD when we are managing people with diabetes. So just think of all the people who come into you, and you should at least ask them about bone health, about bone illness. How are you doing? Do you have any aches and pains? Do you have any proximal muscle weakness? Do you find it difficult to get up from squatting position? Are you able to offer namaz? Are you able to offer obeisance in the Gurdwara Sahib? Are you able to bend and pray in the mandir, in the temple? These are simple questions that can be asked. All osteoporosis is not going to be symptomatic. So if you have a person who is postmenopausal or an elderly male, then it would be a good idea to do DEXA every year. That is dual energy X-ray absorptiometry for bone density. If your patient cannot afford DEXA or it is not available, you can just do a FRAX tool assessment. FRAX. Go on the internet, type in FRAX, FRAX tool, and you will get a free link from Sheffield University. Just go into that and click Indian and click all the other parameters that are asked for. Even if you have no parameters apart from age and gender, and of course Indian ethnicity, that also will give you a fracture risk assessment. So we have to be osteovigilant. Another factor where we have to be osteovigilant is in terms of medication. So some drugs like pioglitazone can actually increase the risk of fracture, atypical fractures. Also, in diabetes, calcium absorption may go down. So we may need higher doses of absorption of calcium. Usually we prefer calcium carbonate. Calcium carbonate has got 40% elemental calcium. The other one that we use is calcium citrate. This has got 20% of elemental calcium. So 40% elemental calcium in calcium carbonate, 21% elemental calcium in calcium citrate. Calcium carbonate is better absorbed with meals because it needs gastric acid for absorption. Calcium citrate is better absorbed on an empty stomach. Both should be taken at least a few hours apart from thyroxine dosage, or at least 30 to 60 minutes after semaglutide dosage. Calcium carbonate is usually well tolerated, but if it causes epigastric fullness or constipation, then we may consider shifting to another preparation like citrate or any other preparation. But these are the two ones which I use: calcium carbonate in routine and calcium citrate for those who are not able to tolerate carbonate. Other things related to osteovigilance, if your patient has poor bone mass or poor bone quality, that is osteoporosis, then when you are telling the patient to exercise, encourage low impact exercises. At any given point of time, at least one foot should be on the ground. If patient is not able to do any aerobic exercise, they can do sitting exercises like yoga or sitting yoga or lying down exercises. For those with vitamin D deficiency, we should encourage people to undergo outdoor activities or undertake outdoor sports. This will help improve sunlight exposure and vitamin D synthesis. The same skills that we have for insulin initiation, insulin motivation, those skills should be utilized to enhance adherence to therapy for osteoporosis, whether it is calcium vitamin D, whether it is denosumab, which is an injection every 6 months, whether teriparatide, a once daily injection for osteoporosis. Apart from drugs, we should also look for risk factors. So pioglitazone is one risk factor. Others are hypogonadism in men and women, that is late onset hypogonadism in men and menopause in women, especially those with early menopause or those with premature ovarian insufficiency. Here, the risk of osteoporosis is much higher. So all postmenopausal women must be given calcium and vitamin D, and if indicated, HRT, hormone replacement therapy. If you have a lady with premature ovarian insufficiency, that means she has developed ovarian insufficiency at an early age, below 35. Whether surgical, iatrogenic, or natural, medical, we must supplement with HRT, with hormone replacement therapy or menopause replacement therapy up till the expected age of menopause, which is around 47 years to 49 years in India. Hypomagnesemia can also be a cause. If a patient has tetany and calcium levels are normal, then we will suspect hypomagnesemia and test for that. But usually it is hypocalcemia, which is more common. If the patient has hypocalcemia, do look for parathyroid health and also do a urine routine for calcium crystals through urine microscopy. If there are calcium crystals, it is possible that the patient has got familial hypocalcemic hypercalciuria. Also look for vitamin D deficiency. Usually I don't get this tested unless I'm confused. And a surrogate marker for low vitamin D is alkaline phosphatase. The total alkaline phosphatase that we do in our OPDs, which I also do, is not very accurate with regards to vitamin D status. But you can do a bone-specific alkaline phosphatase if required. Also, any patient with microvascular complications, neuropathy, retinopathy, nephropathy is at greater risk of fracture. And therefore, we have to be even more osteovigilant in patients with nephropathy, neuropathy, retinopathy. It's not just the nerves and bones that we are worried about. There is something known as Moan syndrome, MOAN. Moan comes from pain. So Moan syndrome says that if a patient has aches and pains, the etiology can be muscular, M. It can be related to osteo or bone, that is O. A for arthro, that is joint, and N for neuro or nerve. So in anyone with aches and pains, look for MON, that is muscle, osteo, arthro, nervous or neural health, and manage it accordingly. Do keep a high index of suspicion for disorders of bone mineral metabolism. Screen patients regularly. Clinically, take a history. We've already talked about that. And also for examination, ask the patient to squat and then get up from squatting position. Ask the patient to raise her hands above her head and see if she is able to pick up a slight weight. This will tell you not only about bone health, but also about muscle health and about joint health. If the patient is not able to get up from squatting position or is not able to squat, that is a proximal myopathy, and the commonest cause will be vitamin D deficiency. Do encourage the patient to follow a healthy lifestyle, to undertake outdoor exercises. Both aerobic as well as resistance exercises are important. For the average patient, for the average individual, 5:7, 2:7 ratio is okay. 5 by 7, or that is 5 hours out of 7 hours total, should be devoted to aerobics, and 2 out of 7 to resistance exercise or muscle building. For those who have osteoporosis, low impact aerobics is much, much safer. And like we've said, whatever motivational skills you use for insulin or for other things, do use the same skills to encourage people to take calcium, vitamin D, and other drugs if required. How much calcium is required? This is what the NIN says, National Institute of Nutrition. They say that it should be a minimum of 1,000 milligrams per day for adults, pregnant women, lactating women. For postmenopausal, they have taken it up to 1,200 milligram per day. And this is elemental iron, elemental. For children, it is much less. But if you see it from a relative point of view, the requirement for calcium is much higher in adolescents, age 16 to 18. It's slightly higher than that for adult men and women. The highest requirement is for postmenopausal women and lactation, that is 1,200 milligram per day, followed by adolescents age 16 to 18, 1,050 milligram per day. The vitamin D requirement has also been increased, and it's 600 units per day for everyone except infants, where the requirement is just 400 units. Do note that these are physiological requirements for normal people. If your patient is sick, your patient has osteomalacia or rickets, then certainly a much higher dose of vitamin D will be required. Something like 10,000 units per day. So to summarize, we've talked of osteovigilance today. Let's see what the questions are. And we've mentioned why osteovigilance should be given place of pride in the management of diabetes. All you have to do is to take a history of aches and pains, and then take a history of proximal muscle weakness. Ask for history of fractures in the past. Look for all the risk factors. Do a urine routine if required. Do a vitamin D if required. A PTH if required, but you will not need that very rarely. Usually, by just supplementing calcium, you can improve the health of patients. Calcium, roughly 1,000 milligram per day in every adult. Vitamin D, roughly 600 units per day in every adult. This supplementation should be done. This is what osteovigilance is. Choose any calcium that you are comfortable with. Carbonate has more elemental iron than citrate. Citrate is better absorbed, is better tolerated by the gut, by the GIT. Do remember not to give calcium along with thyroxine or with semaglutide, and do not give it along with iron as well. Keep it as far away from iron tablets as possible. So this is what we had to discuss today. Let's come to our question. Fill in the blank, please. Insulin increases bone formation. And if dash is left untreated, then there will be bone loss. So what leads to bone loss? Is it cancer, diabetes, nausea, or headache? So insulin increases bone formation. We are comfortable with that. It is an anabolic hormone. It is osteoanabolic, myoanabolic as well. And if dash is left untreated, then there will be bone loss. The dash can be cancer, diabetes, nausea, or headache. So let's see what the answers are. We have talked today about osteovigilance. And let's see our questions. Lots of questions coming in. Good evening, everybody. And so Creative Folk says, eating calcium carbonate like you have with pan, will that solve the problem of calcium deficiency? Partly yes, but mostly no, because the quantity will not be enough. We need 1,000 milligram, and calcium carbonate has got 40% elemental calcium. So which means we'll need something like 2,500 milligram. That is 25 grams. That's quite a bit of calcium carbonate. In fact, when patients come to you and say that I feel like eating chalk, that is usually a sign of or a symptom of iron or calcium deficiency. So Dr. Gauri Shankar says, could you repeat the dose of calcium? Roughly 1,000 milligram for everybody in general practice, and also people with diabetes, especially those who are older, those who are postmenopausal, those who have had a history of fracture in the past, a history of fracture in their family member, or those who have proximal myopathy or aches and pains. And again, Dr. Dharmaraj says, shall we give prophylactic vitamin D to all women greater than 35 or 40? Yes, ideally, yes. So for every healthy woman aged more than 40, or any man also for that matter, vitamin D once in 15 days is a pragmatic solution, 60,000 units. You can also give once a month. The vast majority of Indians, 90%, are either vitamin D deficient or insufficient. So once in a month, lifelong, is very safe. If you're very much worried about the risk of hypercalcemia, all we have to do is you can check serum calcium. If you don't want to do that, you can just check urine for calcium crystals on microscopy. If there is calciuria, then maybe we are over treating. But if not, you can relax and go ahead. Good evening to Dr. Swaraj. And another question is, should I give vitamin D 60,000 units or 6 lakh units or 0.6 lakh units once a month, or calcium 500 milligram daily lifelong? The answer is both are required. Calcium is calcium. It will go into the bone. But vitamin D will act upon the intestine to ensure that calcium gets absorbed. Then it will ensure that calcium gets taken up in the bone. So both are required, both calcium and vitamin D. For osteoporosis, it is calcium deficiency which is more important. For osteomalacia, it is vitamin D deficiency which is more important. For rickets, vitamin D deficiency is more important. So both are required for bone health. Question is, how do we find out about calcium deficiency in a general OPD? The questions will be, or if the patient presents with tetanic seizures, or generalized aches and pains. Fatigue, anybody with fatigue, we'll do a calcium alkaline phosphatase. If alkaline phosphatase is high, that means osteomalacia. In postmenopausal women or those with history of fragility fracture, we can do a DEXA or we can do a Frax tool estimation. After calcium supplementation, when to recheck? In not before a month or so, usually. Another etiology is hypoparathyroidism. That is not very common, but fairly common in the OPD. Every month I have one patient. And for hypoparathyroidism, even if you keep on giving calcium, you will find that calcium is not going to cross 8 or 9, 7 or 8. It will remain on the lower side, but patient should remain asymptomatic. 50-year-old lady for 10 years, diabetes for 10 years, presented with backache, knee pain, and BMD minus 2.5. This is osteoporosis. So how we should proceed? We should give calcium and vitamin D. If we are sure that vitamin D is taken care of, now you have a choice of 3 drugs. One is the bisphosphonates. Another one is denosumab. And yet another one is teriparatide. If patient is able to accept orally, the easiest would be denosumab 60 milligram every 6 months, subcutaneous injection. Just like insulin, it's a pre-filled syringe. So every 6 months, you have to give denosumab. Or we can give teriparatide. For denosumab, the print cost is about 20,000 rupees per injection. You will get it in wholesale for around 13,000 rupees per injection, and you have to give 2 injections in a year. Subcutaneous, just give it and patient goes back home. Teriparatide cost is around 4,500 to 5,000 rupees per month. You will get a pen which will last 28 to 30 days. Every day you give 1 dose, 20 microgram at night. There is also zoledronic acid, which is once a year infusion. You have to give it like a drip. Or if patient wants to take orally, you can give alendronate once a day or risodronate once a day or once a week. Once a week preparations are also available. So we can choose either of these. Either you will choose an anabolic drug like teriparatide, or you will use an anti-resorptive drug like denosumab or bisphosphonate. In bisphosphonate, zoledronic acid injection or alendronate tablet or risodronate tablet. Choose only one out of these, not more than that. Along with this, if you want, you can give MHT, menopause hormone therapy. If the patient comes with estrogenic symptoms like hot flash, disturbance in micturition, or dyspareunia, difficulty in painful sex, then MHT will help a lot. This is estrogen plus preparation combination. Dr. Gauri Shankar shares another exemplar from his practice. Now 53-year-old lady, diabetes on OADs, knee pain, but all the investigations are normal. BMD and calcium are also normal. And now knee pain and backache are the chief complaint. So first is exercise, graded exercise with a physiotherapist, flexibility exercises for the backache. You can give NSAID for short period of time. Do supplement with vitamin D once a month, even if calcium is normal, and give calcium 1000 milligram even if it is normal. Now, regarding the knee pain, X-ray may or may not help you. It may tell you about arthritis. But if patient has got a meniscal tear or a ligament tear, then MRI will be required. So if knee pain persists, especially if it is unilateral, but even if it is bilateral, we should request the patient to undergo an MRI of the knee. For postmenopausal osteoporosis symptoms, it is asymptomatic until the fracture occurs. And the sign is a fragility fracture. You see that the patient has got a fracture. So every postmenopausal lady should be screened for osteoporosis with DEXA or Fraxtool. The treatment will be calcium, vitamin D, either denosumab or teriparatide, daily injection 20 microgram, or alendronate once a week, or risodonate once a week tablet, or zoledronic acid once a year infusion. What I would prefer usually is denosumab. The cost is about 2,000 rupees per month, not so much, and just 2 injections in a year, along with calcium and vitamin D. And if, like we said, the patient has estrogenic symptoms, then we will add MHT as well. Now, for MHT, we have various options. Though usually we don't use trade names. If you have not used MHT before, then the safest one to use would be a brand name known as Phimoston Mini, MINI, Phimoston Mini. This has got 1 milligram and 5 milligram respectively of estrogen and dydrogesterone, a very safe drug to use. Do rule out the contraindications like CA breast or CA endometrium. Many more questions that are coming on. Is it enough to check calcium alone? No, it is not enough. At least an alkaline phosphatase along with that, a hemoglobin, and ideally a urine routine must be done, urine microscope. Calcium intake does not cause calcification of the arteries. Dr. Nitin has raised this point. The reason is that that is a different type of calcium. And calcium intake actually helps overall health. It even reduces the risk of renal stones. Most of the stones that we see in India are oxalate. If you take adequate calcium, the oxalate will bind to the calcium. You will have calcium oxalate crystals and they will go out through the urine, through the kidney. It is when calcium deficiency is there that the oxalate goes and creates stones. Calcium-rich food would be basically milk and milk products. Cereals also have calcium, but the bioavailability is very low. Yes, and Dr. Dharmaraj raises a very strong point that because patient doesn't have symptoms or signs until the fracture occurs, so it is a good idea to give vitamin D prophylaxis to all women in India. Certainly, it is a good idea. This will help prevent fracture. It will help prevent fall, prevent fracture, prevent death. So all postmenopausal women must get calcium. And like we said, our NIN, National Institute, has increased the requirement now to 1200 milligram per day. Earlier it was 1000. Which calcium shall we eat? Like I said, I usually give calcium carbonate to all my patients. It is economical. It contains 40% elemental calcium. If patient is not able to tolerate, then we move to calcium citrate, which is easily absorbable, but it has only 21% calcium, elemental calcium. In men also, in all elderly men, vitamin D supplementation should be given. Calcium should be given. It will prevent fall. It will prevent fracture. It will improve muscle health as well as bone health. Vitamin D, usually we use oral tablets or sublingual. What I usually do in my OPD is vitamin D 60,000 units once a week. Either oral tablet or oral liquid, sugar-free suspensions are available, or sublingual tablet. All are fine. Once a week for 8 to 10 weeks. Then after that, you shift to once in 15 days for a few months, and then you go down to once a month. There is, however, injection available. It is 6 lakh units and 3 lakh units. So you can give vitamin D injection 6 lakh units and give it once in 3 months. This is if the documentation is there. You have to be sure that vitamin D deficiency is there. Don't give the injection. Don't give this mega dose of 6 lakh units injection if you are just giving empirically without testing. One question is about 3 centimeter of endometrial wall, endometrial thickness in an elderly lady, and endometrial ablation is a good treatment. Blood donation will usually not be required. But if it is a 30 millimeter endometrial wall, already hemoglobin may be low. So for correcting that, that is separate matter. But otherwise, the endometrial ablation itself is a very safe procedure. No blood will be required no extra blood loss is expected during the ablation. It is good also to do endometrial ablation instead of doing bigger surgery like hysterectomy. This way, we are protecting the integrity of the body of the elderly lady, and endometrial ablation is a very safe and effective method. HB is 11.6, then blood donation will not be required. We can relax and we can go ahead. More questions are also there. Dr. Gangadhar Rath asked if prolonged use of calcium increases the risk of renal calculus. So actually it reduces the risk of stone. Like we said, it binds to the oxalate and prevents oxalate stones from being formed. Dr. Vinay Desai shares a case of 54-year-old lady with TSH 11.8, which is high. So patient is hypothyroid. Anti-TPO is high, so patient has autoimmune thyroiditis. So patient has Hashimoto's thyroiditis and is currently in hypothyroidism. Still patient is asymptomatic. That is because it is subclinical hypothyroidism. Hypertension has been noticed and also left axis deviation on the ECG. Yes, we must start on thyroxine. The dose should be a bit higher. Feel free to give a higher dose. Now, the average dose for starting, average, is 1.6 microgram per kg body weight per day. So if the patient is 50 kg, then we will start 75. If the patient is 100 kg, we should start 150. Now, assuming she's an average lady, in this particular lady, I will start with 75. I will tell her that TSH increases in logs and reduces in logs. So we will do a TSH after 45 days. From 11.8, it should come down to around 2.5. If it is there, we will continue with 75 microgram only. If, however, the TSH has gone down to 0, 0.1, 0.3, then we will reduce. We can reduce from 75 to 62.5 microgram. Many times patient will come and argue with you, Doctor Sahab, I bought a bottle which has got 100 tablets. So what should I do with the others? You just reduce the dose. You tell the lady you can take 6 tablets in a week or 5 tablets in a week, and your tablets will not go waste. Another question relates to a 46-year-old lady, 62 kg, fasting glucose 220, very high. Postprandial also high, 335, and HbA1c 11.1. So this is throughout poor glucose control throughout the day. Patient glargine, 16 units, metformin, teneligliptin, glimepiride. This particular patient, yes, if you are able to start basal bolus, very good, and stop the sulfonylurea. So two things we can do. If patient is willing, we can give basal bolus. If patient has got an acute or subacute surgical, medical, or obstetric emergency, which requires immediate resolution of glucose. Any medical or surgical issue like diabetic foot, diabetic ulcer, tuberculosis, anything which requires immediate resolution, then we will start basal bolus. Otherwise, if patient does not have any acute or subacute symptoms or comorbid conditions or complications, we can try premixed also twice a day. So in this patient who is 62 kg, I will begin with something like 30 to 35 units of insulin per day, 0.5 unit. I have already tried 0.25 units. I have already tried glargine 16 units per day. Patient is not doing well, nowhere near control. So let me make 16 into 32. But if I give 32 together, I will feel afraid. I may cause hypo at night. So I will give either premixed insulin 16 units 2 times a day, or I will shift to basal bolus. Basal bolus 32 may say around 16 units or 12 units I will give to basal. So I can continue glargine 16 units, and I can add maybe something like 6 units 3 times a day of rapid acting insulin. Then I will titrate after 4 or 5 days. I will tell the patient that glucose is not going to come down fast, but don't worry at all. Within 3-4 days, you will get a feeling of well-being. You will get a feeling of well-being. Your cheeks will fill out, madam. You will begin to feel better. People will actually say that you have become more beautiful than before. And then your weight will begin to go up slowly. You will feel good. After about 10-12 days, after about 7 days, your postprandial glucose will fall. Postprandial excursion will fall. So fasting may still be 200, but BP will come down to 240. And after that, fasting glucose will come down, because fasting glucose does take longer time to reduce. So we'll monitor the glucose for for basal separately, for rapid acting separately. Basal dose will be determined only by fasting. For the bolus dose, whether I'm giving Novorapid 6 units as an adequate dose or sub-adequate, I'll do pre-breakfast and post-breakfast. Pre-lunch and post-lunch, 2 hours. Pre-dinner, post-dinner. I don't have to do all on the same day. I can do a staggered monitoring. Monday, I did pre-breakfast, post-breakfast. Wednesday, I did pre-lunch, post-lunch. And I count the excursion. Post-lunch minus pre-lunch. Ideal should be less than 40. Up till 74 is still okay. If it is above 74, the excursion, we will increase the rapid acting insulin by 2 units. If it is below 40, we can reduce also by 2 units. And on the other side, for glargine, we are looking at it separately. So we just keep on increasing glargine until we reach a fasting of 100 or so. So for this patient, the question was what dose to give. We will stop glimepiride. We will change teneligliptin to a better gliptin. Linagliptin, sitagliptin, vildagliptin, all will do. And either we will give rapid acting 6 units 3 times a day, plus glargine 16 at night, or we will give premixed 16 units twice a day, and then we titrate further. So many questions that we have today, and related to calcium, related to other things as well. And this is actually what makes me feel very happy, that we are all discussing how to help our patients. If there is anything else we can do for you, please let us know. Do not hesitate. Do not hesitate to reach out. I'd like now to hand over to Team FDC, and perhaps Team FDC would like to talk about iron as well. We've spoken about calcium today. Last week we spoke about iron, and there were so many questions, so many insights that I got. Perhaps Mr. Rahul would like to speak about what we are going to do regarding iron and health.
Yes, sir. So last week, the number of questions came across from all the doctors, Dr. Kalra. We have decided that very soon we will be starting off an module called Iron Talks with Dr. Sanjay Kalra, where 10 different topics pertaining to iron and anemia in children, in cancer patients, in pregnant women will be taken across. So I won't divulge the details entirely right now, but please do stay logged in touch with us very soon. We will be starting with this module also on the same platform itself in the month of September. Thank you, sir, for taking all the questions, and thank you, viewers, for taking out time on the Sunday evening and logging in for this module. Thank you so much. Good night.
Jai Hind.